So this is just a brief review of Chapter 19 on population, aging, and health. They're all connected together. We'll focus primarily on aging since that's the nature of this chapter. The big questions, of course, are how do populations change over time? What happens to aging societies? How do social contexts affect health? And who gets sick and why? How do populations change over time is an important question. One of the things that you notice is that the world population is doubling throughout history. Every population change over the course of the population changes that double from 1 to twice as much are taking less and less time to happen. So, for example, in 1967, the world population was 57 million. It's now doubled to 45. The number of years was 57 years between 1910 and 1967. Now it's less than that, and that's only been 43 years. So it's 45 years. This happens very quickly. Understanding the population, though, is important, and this really has an effect on aging. The detailed understanding of the processes underlying birth, death, and movement in and out of populations and out of countries. It also describes changes in fertility, mortality, and migration, as well as the causes that make these changes happen. The first demographic transition is the initial pre-transition between highly fertile and high fertility and high mortality. In other words, there's lots of babies being born, but also lots of them dying. The transitional period, when mortality first starts declining, is also followed shortly by a decline in fertility as well. The post-transition period is one in which both fertility and mortality are quite low, which is where we're at right now. Changes in fertility and mortality can be seen around the world. In the Sudan and North Africa, during the first demographic transition, rapid decrease in mortality, but much later and slower decrease in fertility. So they keep having babies, the population keeps rising. Whereas opposed to the United States, we're in the first demographic transition. Toward the end of it, the age pyramid is much higher after 60. There's only replacement fertility, that is, that the population is growing more slowly than other countries like the Sudan. And then in Japan, they've completed the first demographic transition. That and places like Sweden, who at one point had actually a negative population growth. They were shrinking in size. And you can study these if you like. You can see where Japan, the United States, and Sudan all stack up against each other. Immigration is an important facet, especially in the U.S. population. It involves both in migration and out migration, people coming and going. Japan is a very small immigration population. Sometimes their countries continue to grow, but their rate slows down, like the United States. In Japan, of course, there's a decrease in the growth rate in itself. Question 2, what happens to aging societies? Well, the epidemiological transition, in terms of the first demographic transition, the impact of disease and health conditions affect countries differently. It refers to the transition of populations from health conditions primarily involving infectious diseases to health conditions involving chronic diseases. So people in Uganda die from things like tsetse fly infections and malaria, which are unheard of in the United States. People die here from heart and lung disease, and cancer, which are related more to consumption. Chronic diseases are persistent, degenerative risk factors involved, like being obese, and of course they kill people very slowly. You can see the age of the baby boomers in the United States and Japan. Um, and of course, aging baby boomers would be include your grandparents, most of you who are listening to this. Some countries age more quickly than others do, based on environmental and societal factors. Some population measurements for life expectancy, knowing when one might die. Health life expectancy, the number of years of good health you should have. Expected years free of limitations of activities. And of course, expected years of life free from selected chronic diseases like heart disease. The number of physical and mental unhealthy days, which include the number of reported health days, unhealthy days, and chronic disease prevalence. Why has healthcare become more expensive for everyone over time? Partly because of the rising cost of healthcare, the aging of American society, and of course the decline in the number of young people to help shoulder the cost of this care. The rise of chronic diseases causes death, creates new challenges for end-of-life care, which not only keeps people alive longer, but means that the healthcare costs go up. Slower and longer courses of dying. So one of the challenges of living longer, of course, is the fact that chronic diseases mean extended, slower, and longer course of dying. So the trade-off is people live longer here, but in the United States, but they also tend to have more chronic disease states, which affect longevity, obviously. Of course, there are some heroic methods in medicine in the United States. Some people choose to follow those, some don't. And of course, one of the issues that people, as they age, have to do is discover or decide about advanced directives, what you want your family to do for you at the end of life. Palliative care refers to keeping people comfortable as they're in the dying process. Typically, this is synonymous with hospice, which of course is, depending on the state that you live in, typically the last 3 to 6 months of life. Sometimes it can be 3 to 6 weeks or 3 to 6 days, depending on the person. Different places around the world deal with it differently. Sometimes end-of-life care is handled extensively, like in the United States, but in other countries, especially third world countries, it's not. There are differences in the quality, the cost, the availability of end-of-life care around the world. We're perhaps fortunate enough in the United States to have hospice. Other places may not. In developed countries like the UK and Australia, they're consistently rated to provide the best quality of care, in spite of, as the United Kingdom or Great Britain, it being rationed or state-sponsored health care. India, Uganda, Brazil, Chile are rated among the worst, and I can testify to that in Uganda because we went there a couple of years ago on a medical trip, and the medical conditions are really bad. Question 3, of course, is how do social contexts affect health? A sociological view of health, sociologists tend to focus on social causes of disease within populations rather than the immediate cause of an individual's illness. So, for example, with this COVID-19 outbreak, what are the social factors that lead to the spread of infection? We might study that. In fact, I'm sure once COVID remits, that there'll be many books and studies published on the sociological factors. consider how social contexts shape individuals' health behaviors. So just the fact that wearing masks, or people's choice to smoke or drink alcohol, or do not exercise, or diabetics that take poor care of their physical health. There are many social contexts. If you live in some states, of course, it was almost taboo to wear a mask. Other states, it's highly encouraged. Again, it's about social context. And of course, the focus is on how the contexts people inhabit throughout their lives affect their health. So it might be that the COVID behavior emerged because of COVID, but the same kind of healthcare decisions and behaviors are found pretty typically throughout that person's lifestyle choices. Sociological approaches to improving health include population models changing the features of the social environment, for example, making healthcare accessible in the work environment, places for people to work out, healthy foods in the cafeteria, etc., and treating the population as a patient, which of course we've seen emerge with COVID-19. Social contexts, of course, sociologists provide recognized context and relationships play an integral role in shaping choices. If, for example, if vaccines are available, what are the decision-making points that people choose to either get vaccinated or not? Don't forget, many people don't choose to get flu vaccines even though they're available every fall. And of course, sociologists ask what features of the social context enable or constrain particular behaviors. What can facilitate wearing masks? Is it punishing people? Is it making regulations, or is it encouraging in some other way? And they also examine how norms around behavior may affect individuals' choices. Social relationships affect our health in three major ways. Through the impact of social influence. So if you're around people that perform healthy social behaviors, you may be more likely to, or the converse. Person-to-person contact. Having a relationship with the doctor understands you, knows you, improves your health care, or your nurse for that matter. And of course, access to resources. In people living in cities didn't have access to the vaccines, especially among poor populations, so it affected their health care in a major way, the lack of access. And of course, healthcare risks accumulate across the lifespan. It's one thing to look at people at the end of life, but one needs to look at all of the choices over the life course. Some of the models are sensitive to these changes. They're called latency models. And some look at cumulative exposure, kind of like radiation in a sense. Some look at social trajectory, how society changes and influences behavior. Especially for who gets sick and why. Well, everyone gets sick. There are health disparities based on social status and health, consistently found across time and place. One theory is called the theory of fundamental causes. It blends multiple dimensions of the socioeconomic status. Higher socioeconomic status individuals have more knowledge, more money, more power, and more social connections throughout life. There was a story about the governor of Ron DeSantis of Florida getting people with high socioeconomic standing the vaccine. So before people of lower socioeconomic status, those connections make a difference. Socioeconomic status gives people the ability to make use of knowledge about how to improve their health care. And one thing that's kind of leveled the playing field in the last 20 years is the internet. Health and socioeconomic status are important. Education through direct effect on health care. Better health behaviors of more educated people explain 40% of their health advantage. Just knowing how to take care of yourself. Income and wealth also mean the person can purchase better food, safer environments, and better medical care for children. family's income affects the child's health increases across over time from childhood to adulthood. And of course, the effects are largest for the poorest. So the poorer you are, the less access to healthcare you have. And of course, occupation also makes a difference. Whitehall studies found that those with higher socioeconomic status experience less psychological stress. And you'll notice that education, income, and wealth and occupation are all three of those major stratification measures that we talked about at the start of the semester, or start of this chapter. Toxic stress related to cardiovascular disease and range of other illnesses are good examples. And finally, why do African Americans have worse health care and outcomes than non-Hispanic whites? Could be a couple arguments. One is that there's a genetic explanation. Their racial differences represent actually class differences, not racial differences. And the psychological stress of people living in certain environments affects their health more than other groups. The quality of healthcare treatment also is limited in some urban areas. What do you think? And that's it.